Welcome everyone, my name is Magali De Castro. I'm the Clinical Director here at HotDoc, and today in this webinar we're going to be talking about some highlights from the 15th National Immunisation Conference, which I attended a couple of weeks ago in Brisbane. Now this webinar is brought to you by HotDoc. Now at HotDoc we pride ourselves in providing relevant information and practical education and training for GP clinics across Australia, just to make life a little bit easier, because we can usually use any help we can get to make our life a bit easier in our practices. So if you have any questions about how HotDoc can assist, don't hesitate to contact the support team. But for now, let's just get started with this webinar. Right, so we'll be talking about today is essentially the Immunisation Conference that took place in Brisbane between the 7th and the 9th of June, so earlier in the month. And the theme of the actual conference was the jigsaw, so immunisation, the jigsaw, fitting the pieces. 1 second, sorry. One moment, I'm going to have to tweak a couple of things here. Here we go. Panel wasn't allowing me to read the full thing. So immunisation, the jigsaw, fitting the pieces 2 decades on. And yeah, it was a fantastic conference. So I'm not sure if any of you were able to attend. It was really lovely to see a lot of familiar faces there. Incredible presentations, lots of both local and international speakers, very inspiring. And it's always really inspiring to obviously see how many passionate people there are out there who are doing great things to improve immunization and coverage rates. So with this conference, a big thing or theme was celebrating that it's been 20 years since the introduction of the series of measures to improve coverage rates, which was the sort of the umbrella of Immunize Australia. And to this day, we still have the Immunize Australia website, and this is also the time of the introduction of the Australian Childhood Immunisation Register, so ACIR. So that's been 20 years since the introduction of that initiative. Now, since then, since the introduction of the ACIR, we have seen immunisation rates climb from 75%, so it was 1997, all the way up to 91.4% in 2010. We know that at the moment we're still striving to reach that 95% coverage rate, and we know that coverage rate varies depending on different areas and sort of hotspots throughout the country, but also it varies depending on different cohorts, and specifically with adult immunizations we're not doing anywhere near as well as we are with children. Another thing to mention is with the human papillomavirus, the HPV initiative, which is a relatively recent initiative. We already have a coverage rate of around 66% in boys and 78% in girls, which is fantastic considering how recent this initiative is. So in terms of the actual conference, and obviously as you can imagine, it was 3 days jam-packed full of information. There were, however, 4 key areas that kept coming up time and time again. So these 4 key areas were: 1, good, clean, reliable data. So how are we collecting and recording all of the immunization doses that we're administering, including obviously, how we're using the register. Then the second area was good coverage. So what are we doing in terms of improving our coverage rate? Again, looking for that target of at least 95% Australia-wide, which will provide that herd immunity and expanded or extended protection to the rest of the population. The third area was effectiveness of vaccines. So, are we making sure that we're getting bang for our buck, or essentially that the vaccines are actually protecting the population the way that we intend them to? And the fourth area was safety of vaccines, or what we call surveillance. So obviously checking that we're not causing harm, but when we have had when there have been adverse events, or when we had, for example, the increasing incidence of febrile convulsions in children with the flu vax back a few years back, that we actually can very quickly react, respond, and put things in place to obviously make sure that we protect our community. So these are the kind of 4 key areas that are very much on the radar when it comes to public health, but also from a policy development point of view. These are the key, key sections, and I'll talk a little bit more about them in more detail. All right, so first we have comprehensive immunization data. This is not just looking at how we record immunization encounters and doses at point of care. Obviously, that's important. So this being at the clinics, that obviously as soon as we administer any kind of dose, we're documenting that in the correct way, in the right place in our clinical software so that it can report through. And we can search that data, and it's not just hidden somewhere in the progress notes. But more broadly than that, it's also looking at how we're reporting to the registers such as the ACIR, or the Australian Immunisation Register. There's a lot of work taking place in this data collection space because obviously we need good, clean data so that we can inform any initiatives, any new campaigns that we roll out, any changes that we're going to create, but also so that we can have a view of how well we're doing or where we might be, where we might need improvement. So with all of this, we know that recently we had an expansion in the immunization register that it's now capturing children up to, well, up to 20 years of age. But later in the year, it's going to be capturing pretty much whole of life because we're looking at including also the adult immunizations. And this is going to be in preparation for the shingles vaccine rollout in November of this year. There was a lot of talk around, obviously, the immunization register is great, but it still needs a bit of work because there are still some glitches and issues with the accuracy of things being documented and even in the transmission process, which I'll talk a little bit more about as well. The register will be changing from ACIR, which is at the moment the Australian Childhood Immunisation Register, to AIR, which is just Australian Immunisation Register, obviously because it's now going to be covering pretty much whole of life. One of the interesting things is that historically, whenever we attended these conferences, and we had representatives there from the Department of Health and politicians and that kind of stuff, and they would always ask, what do you want as the healthcare providers? And we're always saying we want a whole of life register. So we finally, after obviously all that that asking and begging and pleading, we finally looks like we've got the start, so the beginnings of one. But obviously there's still the teething issues as we develop it further. So the other great thing to aim for, which is something that's been discussed, is getting to the point where we can have two-way communication between the immunization register and our clinical software packages. So again, this is still a little while away, but how amazing would it be if we can just open our clinical software, we're inside our patient file, and we can actually see what we're doing, but we can actually also see their immunization register documentation, so we can see what is showing as overdue, what services we're providing that are immediately sort of updating, and obviously it'll make all of our lives a lot easier. But that's still a little while away. But that's sort of what we're aiming for in the future. So as I was talking about before, there are some concerns in terms of the electronic transmission of data to ACIR. There was a particular clinic that even did an audit of their data to see where the gaps were. So in their audit, and this is essentially this one clinic, they found that sometimes their clinical software was failing to transmit the up to or close to 30% of the immunization doses that they had recorded. So they had accurately recorded them in their clinical software, but there were issues with or failures in the transmission. And the biggest problem is that there was no real prompt to alert staff that these transmissions were failing. So they was only really discovered because patients or parents were coming in, contacting the practice going, hey, my ACIR record or the ACIR record of my child is missing information, which, as you may know, will be affecting some parents or family benefit payments. And this is quite a complicated setup because a lot of the times is if their Medicare and Centrelink records aren't connected, again there'll be issues. But they started getting a couple of patients contacting the clinic with this concern, and that's what prompted a further look into what's happening with our transmissions. So they actually looked at over I can't remember the exact period, I believe it was over a couple of weeks, the transmissions, so all the immunization doses that they recorded, compared to then looking directly on the ACIR website, to see in the records of those patients to see how many of those doses that they had documented in the clinical software had actually successfully been transmitted and were showing on ACIR. So that's where they discovered that there was that close to 30% failure rate and no way for them to know that that was happening. So it appears the most reliable way to make sure that anything that you report is actually going on the ACIR register is if you do it through the Immunization Register website or their portal directly. But as you can imagine, this is really time consuming, so it's not ideal. So the recommendation at the moment really is if you've had any patients that are coming through with some of these concerns, it might be worth doing a very quick audit. It might be just a couple of days just to keep track of who are we immunizing, and that should be transmitted automatically to the register, and then checking a day later with the register to see if it's actually reflecting. If it's not, then alerting your clinical software provider, because it's not until they actually get those reports from us, essentially us in the clinic, going, hey, it's not working, this is an issue, that they can have enough information to explore it further and see what's going on. Interestingly, at the moment, this is data from the register. They're letting us know that 60% of reports are happening automatically. So they happen from, just enter it in the clinical software, and as part of the batching and all of that, it just happens electronically. 30% of providers are reporting directly through the ACIR website or their portal, and only 10% are now doing it manually or using any of the other forms of notification. So especially considering that the majority of the notifications are happening electronically, it is important to obviously make sure that that's accurate and that they're actually being recorded. Now, in terms of vaccine effectiveness, are they working? Are vaccines working? We have all these vaccines on the schedule, more being added on a regular basis. Is it worthwhile? Well, we see that it definitely seems to be worthwhile, because we've had a drastic decrease in vaccine preventable diseases. We know we've successfully managed to eradicate diseases like smallpox and polio from Australia. We still have polio in other areas of the world, so the battle is not entirely over. And also with other vaccine preventable conditions, we've seen that they've become extremely rare in Australia. So much so that they often say it's been so effective that it's even fueled the refusers or the anti-vaccination people, going, well, what's the point of vaccinating against these diseases? We don't even have them here anymore, which is unfortunate. We say, well, the reason we don't have them is because it's a really effective initiative or way to go about it. Immunization in general is. So yeah, it's sort of an unintended sort of consequence of that. The challenge with that, obviously, is that they haven't entirely been eradicated. So we've seen outbreaks of measles, for example, recently in Australia, and even where clinicians haven't actually had any exposure to clinical presentations of it. So there might even be delays in diagnosis because we've managed to make them so rare in Australia. So the other area that I found quite interesting is the effect of immunization in children, if we look at the impact that it has. And so some stats to give you a bit of a rough idea. It takes about 16 children. So if you specifically with influenza, if you vaccinate 16 children, you will prevent one influenza-related GP consultation. So that's one child becoming so ill with influenza that they're needing to see the GP. Then if we immunize 117 children, this will prevent one hospitalization, so one child being hospitalized. And then if we reach the 2,205 children immunized, this will actually prevent an influenza-related death. So this will give you a bit of an idea of how these numbers work. And obviously that it is a numbers game. The idea is to provide as wide coverage as possible. The area, as I mentioned before, that remains a challenge is adult vaccine coverage, which it's still far lower than we would want it to be. So it tends to sit, yes, between as low as 50 or so percent, up to, I think, the highest we tend to get. We struggle to break the 80%, and I'm talking about more like pneumococcal and influenza vaccination in the adult population. All right, so in terms of vaccine safety, there is certainly a gradual shift towards what we call active surveillance. So historically, we've had what's called passive surveillance, which is we administer immunizations and we wait and see, obviously, if there's an adverse event, then that'll get reported, but it's sort of left up to the health professionals and it's left almost to the patient to report when something happens. We're now moving to an active surveillance process, which is we proactively prompt as soon as someone has or following an immunization event, we're automatically prompting patients to see, have you had any adverse events, the severity of those adverse events, and was any additional clinical or treatment needed because of that. So what we're seeing is an increased use of SMSs to actively check for adverse events following immunization. So the way this sort of works is you would have your immunization encounter, and then after a period of time, usually a couple of days, you would get an SMS that goes, hey, we know that you've recently had an immunization. Have you had an adverse reaction? Yes, no. And then obviously, depending on what you ask, what the patient answers, it'll prompt them for additional information, or obviously prompt them to contact the clinic for support. Now, when we look at a summary, so with all this data that we're collecting, so this is very much being done as well from a government level and sort of policymakers kind of point of view. From all that data that we've been collecting, we look at the NCIRS publishes their summary of surveillance, the report of summary of surveillance, that gives us an idea of how we're doing in terms of adverse reactions and the safety of our vaccines. So from the recent data, we know that the incidence of serious events remains low, which is a good thing, because what we have is we've actually had an increase in the number of vaccines in the schedule. So we have more vaccines now than ever before. And even though that being the case, the incidence of severe events still stays quite low, which means that obviously the vaccines that we're introducing are still within a very, very good safety profile. In terms of what's being reported as adverse events, none of this is going to come as a surprise. As with most vaccines, the things that are most commonly reported, and this is again of only the adverse events reported, this is not of all vaccines given. The majority of people don't have a reaction, but of the ones that do, these are the most common. Injection site reactions accounting for 27%, fever 18%, rash 16%, and fainting 5%. And obviously severe reactions tend to be even lower than that. There was also a lot of presentations surrounding vaccination in pregnancy. So this has become a really hot topic. So the safety specifically of influenza and pertussis vaccination. And again, it's great to see, it's actually very reassuring that all the information is quite positive and reassuring of the safety of vaccinating during pregnancy. So for example, it was a study following over 9,000 women who were receiving the flu vaccine during pregnancy, and the result was there was actually no association between a mother receiving the vaccine and any change or variation in birth weight or gestational age when compared to mothers who had not received an influenza vaccine. The other key point with this is pregnant women are actually a high priority group for influenza vaccination, because we know that the consequences of them sort of coming down with influenza during pregnancy and the possible complications can be quite severe. So they are really actually a prime high-risk group that we should be prioritizing and making sure that are adequately immunized. And yet an estimated 40% of pregnant women usually tend to go unvaccinated. I have a feeling this is going to gradually change. Obviously, as health professionals, the more we're seeing this data that's reassuring that it's safe, the more we're going to feel comfortable, obviously, recommending it. And obviously, we know recommendation tends to be quite a big thing in terms of someone taking on a vaccine or accepting a vaccine. In terms of pertussis vaccination during pregnancy, we also know that it can prevent 91% of infant infections. And this is because the majority of times infant infections with pertussis are contracted from either parents or direct contacts, usually parent or grandparents or people in their immediate vicinity. The uptake of pertussis vaccine in pregnancy rose from 2% in 2014 to 62% in 2015. And this is obviously, again, part of, the more we have safety data, the more things are then going in as an official recommendation into guidelines like the Immunization Handbook. Obviously, the more comfortable we feel promoting these initiatives and administering them to our patients. So in terms of coverage rate, again, we know that good quality data is essential. There's been identification that a lot of these overdue children, or people who are seemingly overdue, are actually up to date, and it's more to do with errors or omissions from the ACIR or the reporting to the register. And that's actually what's impacting on coverage rate. So there are a lot of councils and PHNs that were doing some data cleaning exercises with working with local communities and sometimes clinics to look at, to check how many of those children were actually overdue. And in some instances, even up to 40% of the children who were showing up as overdue were actually up to date, and it was just more an error of an incomplete record in the immunization register. The topic of the vaccination objectors or refusers, they're still only a small proportion of the population. It's not, sometimes the media can make it seem like, they're out of control and most people are now refusing immunization, and that's actually not the case. It's only 3% or around 3% of the population, or parents, that are the sort of true hard and fast immunization refusers. And this is largely unchanged in over the last 10 years. Which again, like you think from advertising and media, that again, like the anti-vaccination lobby and movement is just out of control, and it actually has been kind of kept relatively at bay, fortunately. The other interesting thing that has come out is from the official advice from the World Health Organization is that there is no one way or silver bullet when it comes to engaging with vaccine objectors or the refusers. There's no one magical solution that is going to make them switch. So it's obviously very much about communication, open dialogue, not being dismissive with them, making them feel heard. A lot of the times these objectors and refusers get to that, especially the ones that are just unmovable, can get to that position because they have had a negative experience with the health sector. Sometimes it may have happened during pregnancy or at other point that has led to a big mistrust or distrust of the system. And so the advice is kind of like, well, with these hard, non-moving type people, sometimes it's probably better not to worry too much and not to sort of spend too much energy in trying to convince the ones that are just not going to be convinced. However, focus your efforts more on, there's a big proportion that are more hesitant. So they're hesitant. They're not a hard no. They're just unsure, and they just need reassurance and more information. For those ones, it's more to yet that perceived lack of information, that they just want to make sure that they're doing the right thing for their children. So in this instance, we do know that a recommendation from a health professional can be quite powerful. And again, it's about having that open communication where they feel that, they trust you, and you're listening to their concerns and addressing them with good, solid, robust information. So there was also some work done into access to reliable information. So again, what happens if I look on Google and I'm a concerned parent? Am I going to be bombarded with negative anti-immunization information? So it was an audit about immunization information available when you're doing a search in Australia. So trying to see what the average parent would come across doing a search in Google. And out of 700 pages, based again on the more common search terms, around 95% were actually supporting or pro-immunization, and only 5% were anti or not in support of immunization. Having said that, so it's still kind of reassuring to know that the majority of the information was pro-immunization. The issue with this was when they looked at the quality of the information, they saw that the more reputable the source, so the more it's a scientific the information was, the more medical terminology and things that would alienate your average punter were present in those sort of publications. So, and then the ones that were more accessible, tending to not really have a clear give a clear indication as to who's the author of that information. They didn't necessarily have good referencing, or it wasn't really transparent who owned that site or who was managing that site. So it's definitely there's still a need for good quality immunization information that can be easily found, that is transparently authored, well referenced, but also most importantly that it's written in a way that is easily understood by, again, if you imagine the average parent who's concerned and just wants to make sure that they're doing the right thing for their child. Another great initiative that was showcased is the Immunize Melbourne initiative, which is run by the Northwestern Melbourne PHN. And the idea with this initiative is they're showcasing local parents in promotional immunization communications. But their way that they showcase them is it's real stories, and it's in a way that's more relatable and more sort of emotional and real for other parents who are in the similar situations. So you can check out the website, the Immunize Melbourne website, because they have a lot of posters and videos and sort of handouts or fact sheets. And again, the idea almost came from when you look at the anti-vaccination groups. They're coming from a very fear-based, and again, it's very emotional-based response to, either conspiracy theory or this is how it's going to affect your child. And so this was kind of taking that concept and turning it on its head and going, let's go again with using some real cases, real people, and again, using that emotional connection to, yeah, I can relate, I can see myself in that case, but again, from a positive point of why these parents decided to immunize and what their decision process was. Originally, this was based on a concept that was developed by the Immunisation Alliance in Western Australia, called the I Immunize campaign. But again, so it's been adapted, and more resources have been created. So this could be a great. It's a site that I would recommend providers check out, because it will give you ideas, or you can even print out or download resources for your practice. Now, one of my favorite things was in the space of innovation. There was a presentation about a new development that is still being tested, and it's still sort of in the researching stage. It's not commercially available yet, but it's a Nanopatch vaccine administration technology. So this Nanopatch, as you can probably see in the image, is quite a small, little, like a chip almost, that just gets applied to the skin for, I think the idea was to get it to around a minute or so, and then removed. And it is obviously, if you can see, there's an image where it's comparing it, the size of the Nanopatch in comparison to the size of a needle, and it's teeny tiny, and each one of those dots would contain vaccine antigen in them. So it's obviously a lot less painful, and the promising results are showing that it's actually much more effective, or as effective, if not more, and the immune response that the body's having is a lot quicker because of the mode of delivery and because of the way that the way that the body or the skin, the receptors, and because of the mechanics of it, how then the inflammation response and all of that is assisting with a quicker uptake of the antigen. The other thing is it requires a much lower dose of vaccine for it to be effective, which is great. But also it can be done as the vaccine is dry coated on the Nanopatch, so on the little mini micro needles. And by it being a dry coated thing that actually gets moist once it makes contact with the skin, and then obviously when you remove it, it just stays behind, the antigen stays behind. It means that by being dry, it's actually stable outside of the fridge, which is not just a good thing, because it means that then you wouldn't have to worry so much about your cold chain and your 2 to 8 degrees monitoring, but more importantly, it makes it easier to get these vaccines to reach those hard to reach areas. So if you're looking at rural areas, definitely, obviously, if we're looking more like remote populations, or places in Africa where cold chain is just not feasible, or it's an incredible challenge. So so it's a very exciting, watch this space sort of area, the Nanopatch. Can't wait to get my hands on that eventually. And the other The other thing that I found quite interesting is there's a study called the Miss Bear study, which is done at the moment. And this is an active study in collaboration between the Royal Children's and Mercy Hospital in Melbourne. And they're looking at the use of BCG vaccine for other purposes. So BCG vaccine, historically, as we know, has been used for tuberculosis. We don't really have it anymore as part of the routine schedule because, again, tuberculosis is not really an issue in Australia anymore. It is still an issue in other parts of the world, with over 80 million doses being needed, well over that. I think it's much higher than that, to essentially to save lives every single year. So what they've discovered, though, there's a huge body of evidence that suggests that the BCG vaccine is not just good with prevention with tuberculosis. It actually also has a further protective effect. And they saw that with children in Africa, there was even a protective factor of around 10% in reduction in mortality from all other causes. So when looking at this further, they saw that, well, actually, can we use this? Can we potentially, does it mean that we can use this for something else? So this study at the moment is it's involving 1,400 babies, and it's looking at how we can use BCG vaccine to help prevent infections and reduce sort of the allergy-based type diseases like eczema, food allergy, hay fever, and asthma. So there's even studies suggesting that BCG vaccination can provide some additional protection for the future development of melanoma of up to 60% of a protective factor, which again could be incredible. But we're seeing less, like obviously the majority of people in Australia are not having this vaccine anymore because its main indication is tuberculosis, and so it's not really an issue. So the rationale behind this is that it could possibly be related to the fact that obviously we're living in such a clean society and a sterile environment that kids are growing up in, and we have that absence of microbial exposure, which could help build up the immune system. So we're looking at, well, perhaps the BCG is actually helping replace that, and then having all these other protective effects or benefits. So that's an active study, so it'll be very interesting to see what happens with that. Could be quite revolutionary. Unfortunately, we know that we have a shortage worldwide of BCG, but perhaps, if we do come up with findings like this and there's a big push and we see the benefit for other things, then that might lead to manufacturers then rejigging the factories and getting them going again for BCG vaccination. And then the last thing that I wanted to mention was also there was talk about the pharmacy-based immunization program. So this is something that a lot of GPs obviously have been quite, or clinics, I should say, practices have been quite concerned about, because, there's a sense of threat of, well, pharmacies are now taking over and doing immunizations. Is it safe? Obviously, it means that, kind of stealing patients away from general practice. So it was interesting to see some evaluation of the trials that started originally in Queensland, which were initially just funded, limited to influenza vaccination. And so I thought I'd share a bit of what that was and what that looked like, so that you have a bit of an idea of how that's working out, because now this is being expanded across Australia and other states, definitely Victoria. And it's actually now expanding as well to pertussis vaccination. But this is how it worked. So it's specifically trained pharmacists, and with the trial, they actually provided 34,000 influenza vaccination doses. Now, when they interviewed the patients who sort of took up this service, 15% of patients reported that they would not have received the vaccination otherwise. So they would not have, if they didn't have the option of going to the chemist to get their flu shot, they probably just would have gone without it altogether. So there's also, when they were surveyed, 99.4% said they were happy with the service and would do it again. So again, this is something that patients are actually quite enjoying. And obviously from a general practice point of view, we have to, potentially learn from some of these things, or are there things that we can use in our practice? Because if this is something that patients are enjoying, well, why are they enjoying it, and can we actually do something similar or take some of those lessons and apply them to the services that we offer. So patients quite liked it, and part of the reason for that was they saw that it was convenient. Sometimes there was no appointment needed, they could just drop in. They didn't have to wait in a germy waiting room, so a waiting room full of other sick people. And also some chemists offered online appointment options, so when people just wanted to make sure that they would be seen at a particular time, then that's what they did. In terms of the people who took up this option, 60% were female in the age range of 45 to 55 years of age, and 67% were over 65, meaning they would have been eligible for the free or the government-funded program for influenza if they had gone to their GP clinic. However, they were quite happy to go to the chemist and privately pay for the service and privately pay for the vaccine, just so that they could have early access, because as you may remember, and this has happened now a couple of years in a row, the private stock has become available before the government-funded stock has reached clinics. So obviously there's a cohort of patients who were quite happy to fork out the money out of their pocket just so that they could be covered sooner. Even though had they waited, they would have had the vaccine. They could have had it for free. So the only other point with this is, as we know, this program is gradually expanding across Australia for influenza and pertussis, but at the moment it's only restricted to adult vaccinations. So they're not allowed or able to provide usually any other vaccines, but definitely not children. So with the influenza program was for people 18 years and over. And I believe that is everything. So if you've got any questions, you can type them into the questions tab of your GoToWebinar panel. This session, there's going to be a recording of this session that's going to be available from next week. So we'll actually have that on our blog. And any questions, if we've got questions now, I'll address them. But if we have too many questions and I can't address all of them, then we'll make sure to address all of them. And I'll also have the list of all the references for all the areas that we talked about in this session. So if you want to look at any of those studies in more detail, you can. So I'll just have a quick look and see if we've got any questions coming through here. Okay. So there was a question about how do you arrange for the SMS for reactions to go out and who is receiving them. So at the moment, so the trial that I was talking about, this was actually a government-based trial. It's actually, I have to remember how, so it was actually through an internal kind of setup, because it was a very specific study and set up with a very specific system. We can, obviously, as you may know, HotDoc has the SMS, the smart recalls that could be set up to do something similar, but you would be using essentially the recall system to send out that prompt. Again, that would be a conversation with the support team. And again, I myself am available if we wanted to have a chat about how we could implement this in the practice. At this stage, again, it's only really being trialed from a government point of view. There's no reason why you couldn't do it from a clinic point of view. But again, let's have a conversation separate to that. Let me see, what else? Any questions? Anything on Bexero coming onto the schedule? There was nothing from the sessions that I attended. I can't remember anything specifically being mentioned about that. But again, I'll have a further look and see. There wasn't really many updates in terms of changes to the schedule. There's obviously all the information on what's happening and what's been developing in terms of things that we would ideally like to add, but there was nothing concrete in terms of the sessions that I attended, where it was mentioned. So there was a question about how safe is it for pharmacists to administer vaccines without a proper medical history, for example, Guillain-Barré syndrome and all that. Very good question. So again, with the pharmacists that are getting this authorization, they are receiving training, and again, it's very specific training. And it's a very limited number of vaccines. So at the moment, essentially, it started out with just influenza, and now it's expanding to pertussis. Very good point in that they wouldn't necessarily have a medical history of the patient there, so they might not really be able to make that assessment. But you'd suspect that again, they would have a pre-vaccination checklist that they're going through, and that if there's any cases where it's becoming a bit of it's sitting in that gray area, then those patients would actually be referred to a GP clinic or to their GP, as opposed to just being vaccinated then and there. So a question, for families hesitant to vaccinate, where would you recommend they attend for advice? Someone, if they're 17. So historically, again, there's been some of the children hospitals have been quite good at providing health advice, like advice to health professionals, and sometimes also. So, for example, in Melbourne, we've got both Monash Hospital and Royal Children's. They're able to actually do supervised immunization of cases where there's an increased risk of either an adverse event or because of the risk profile, or if you have a particularly tricky or concerned parent who just has way more questions and way more issues that need to be addressed than what we would comfortably manage at a GP clinic. So again, it's usually the, I know Monash Medical Hospital, and then the Children's Hospital tend to have those services. Obviously, one of the challenges, and there were people there from the Children's Hospital talking about some of the challenges now, it's with the expansion of the register, you have now people who are, children who are 10 years of age showing up as overdue from their 0 to 7 immunizations, and now having to work up catch-up schedules and things like that, and so they're getting inundated with people wanting assistance with working out catch-up schedules and stuff. So it's also kind of being mindful of trying not to overcrowd them too much, but usually they're there if the assistance is needed. Melbourne address, again, I'm not quite sure what that one. So there's a question about who's giving the training to the pharmacies. Very good question. I think with this trial, I'm not quite sure, but I think with this trial, it would have been based, it would have actually been obviously, like, I would imagine, I would hope, a clinical immunology training, either similar to what the training that a clinician would go through to become a credential, for example, a credential nurse immunizer, or not quite sure. The short answer is I'm not quite sure, but I will list in the references, I will list that study and who were the authors of that evaluation, and then you can actually contact them directly and find out who they were using to train the pharmacists. So mentioned free vaccines now available to non-Medicare card holders under 20 years of age. I'm not quite sure what that would be referring to. Historically, I'm not quite sure if there's been another development, but historically, when we're providing the government-funded program, it's usually for people with a Medicare card. Having said that, obviously, if people are going to places like hospitals or outpatient departments or things like that, and they've got the stock, technically there's, I've never actually seen, this is not official recommendation or official information, but I've never actually seen or heard of an audit of how an audit to a clinic of government-funded vaccines to show that every single vaccine has been given to an eligible person. Like, essentially, it's very much a trust system. And at the end of the day, if you sort of think about the vaccine wastage and the leakage, when you have things like cold chain breaches, it's kind of like, well, you're probably most better off providing immunization coverage, especially if it's going to be a permanent, someone who's a permanent resident. Fair enough not to give it to every single traveler that's just kind of popping in for a weekend and leaving. But if someone's going to be a permanent resident of Australia, it's one of those tricky things where you go, well, you prefer them to be immunized than not, but technically, as far as I'm aware, then so it's saying it is official. Check with Immunize Victoria. Okay, so one of the things is there's going to be a lot of the vaccination programs will vary. So obviously we have our National Immunization Program, and then we also have our state-based programs, because a lot of the times with the more progressive or progressive vaccines or newer vaccines or additional vaccines, it's actually state funded, so they can be different based on different states. So I'm getting the advice here that it is apparently official that for under 20s in Victoria at least, and this would have to be confirmed and double check. I haven't seen it myself, but that would be fantastic if that's the case. Yeah, so it's again making sure that you're checking with your state and seeing what are the vaccines that are going to be funded, or that your state is funding beyond just the National Immunization Program, because sometimes, yeah, you can have vaccine initiatives that are in addition to the NIP for specific populations. You might have for Aboriginal populations, specific at-risk groups. We've had in Victoria, we've had for parents, the pertussis programs for parents. So yeah, so I'm just checking to see if there's any other any information regarding egg allergy and flu vaccine, where there's less risk due to smaller quantities of egg allergen remaining in the vaccine. So at the moment, as far as I'm aware, the recommendation is with the majority of egg allergies and the majority of vaccines that we have, flu vaccines that we have available in Australia, it's no longer a contraindication, the egg allergy, as long as you have, and now you're really testing my memory, it's less than 1 microgram of egg albumin, but that's the case with the majority of influenza vaccines in Australia. So it's not really an issue at the moment, no longer a contraindication. No longer a contraindication if someone's got an egg allergy. If it's a severe egg allergy, again, what I would be doing is I double check the immunization handbook and obviously confirm, like discuss it with a peer colleague, or contact contact an immunology clinician to double check. But for the majority of mild to moderate allergies, no longer an issue. Where do we report serious adverse reactions online? So there's the AEI, the adverse events. I'll post, what I'll do is I'll post it, because again, there is a central reporting line that's both for health professionals and for patients, but there's also state-based numbers that you can use. So what we'll do is we'll report them, like we'll add them as part of the resources when we publish the recording, because I'll have to go off, get all the actual details and put them back in for you. And I think that's all the questions that we have at the moment. So thank you again for participating in this session. And if you've got any other questions, you've got my email there. Feel free to send them through, and you'll be able to access a recording of this session from next week. So it's usually a week after the live webinar. We have it available on the blog, as part of the Hot Dog blog. Thank you very much, and I hope you have a lovely afternoon. See you later.